Well, my name is Shannon Finks, and I come to you from the University of Tennessee. I have practiced in the area of cardiology for about 20 years, and my practice site is inpatient cardiology, and I'm very pleased to be with you. I've taught in the prep course since 2011, and this is one of my greatest joys professionally. And today, I'm going to talk you through the acute care side of cardiology, more the inpatient focused in the CARDS 1 section, and then Dr. Karen McConnell will talk about more of the outpatient management in cardiovascular medicine in CARDS 2. So we are hoping to hit, regardless of where you practice, we're hoping to hit all the high points, but I'll be more focused on inpatient medicine. I have no conflicts of interest. Our learning objectives are available both in your textbook as well as your slide deck. We're going to cover a spattering of cardiology, acute care cardiology, disease states within this section. First of all and foremost, ACS and heart failure, acute decompensated heart failure. We'll talk about life-threatening arrhythmias as well. I will not have time to cover pulmonary arterial hypertension. This is a highly subspecialized topic, and you are better suited having me teach you the basic cardiology disease states that you may see on the exam. Because pulmonary artery hypertension is so subspecialized, I don't know what's on the exam, but I doubt that you will see even one or two questions, because generally this is a critical care issue and it is probably on the critical care exam. So acute coronary syndromes, your textbook or your workbook slides, your chapter and your slides are updated with the most recent guideline changes in this area. And I just want to point out, so that we're all on the same page, the difference in the disease presentations among the acute coronary syndrome umbrella. And so if you have someone who presents with chest pain and you have ongoing ischemia, they can present in several different ways. They're divided into a non-ST segment elevation ACS here, where you won't see ST segment elevations on the EKG. You may not see any difference. You could see an ST segment depression or some type of deviation from baseline that's indicative of ischemia. You may have positive troponins, and then that classification would be a non-ST segment elevation MI. But if you see a patient with an ST segment elevation MI, this is indicative of a total occlusion of the coronary artery. These patients are treated very quickly, and most commonly they are taken, and preferably they are taken to a cath lab where we can open up that artery to supply blood flow to the heart tissue that's distal to that occlusion. So this is treated as essentially as an emergent situation, because time is muscle, and when the heart muscle dies, we end up with heart failure and sudden cardiac death later on. And so this is of acute importance. And the only difference between, as far as drug therapy goes, between STEMI and a non-ST segment elevation ACS is the difference of whether or not we might use fibrinolytic therapy. And fibrinolytic therapy has fallen out of favor in cardiology because we have cath labs available to most individuals. And we'll talk about when you might or might not use a lytic to break up this clot, but preferably know that these patients are going to go to the cath lab within 90 minutes as soon as we can to open up that infarct-related artery. When we diagnose acute coronary syndrome, we do so starting in the emergency department. And many hospitals have chest pain centers, and some of this you're going to evaluate as you get a patient case, and you're going to be given some details that you'll do probably this simultaneously. You'll be looking for clues that say positive biomarkers. You'll be looking for clues on ST segment elevation or not. These type of details will allow you to initially evaluate that patient case. And then we may risk stratify those patients who present with a non-ST segment elevation ACS to either go to medical management, or maybe we take those guys to the cath lab too. And we'll talk about the difference between those. And this is a part of the risk stratification leads us to make a decision on their care and how aggressive we're going to be. And then we'll do some early hospital care across the board, regardless of what subset of acute coronary syndrome the patient presents with, and then everyone who is post-ACS will get the same, or essentially the same secondary prevention. So within that first initial 10 minutes of a patient presenting to the emergency department with chest pain, you're going to an EKG, and you're probably going to give an aspirin within that first 10 minutes. And if the EKG is positive for ST segment changes, such as elevation, indicating again that that artery is totally occluded, those patients are going to go immediately to the cath lab for reperfusion. If the patient has a non-ST segment elevation, we're going to look at those patients a little bit more closely, and we're going to decide, are they high risk? Are they low risk? Should we kind of conservatively manage them with medicines, or should we take these guys on to the cath lab as well? And then everyone is going to get troponins, because that determines also how high risk they are when we're risk stratifying those patients with non-ST segment elevation. And if the first troponin is positive, the diagnosis of MI is made when the troponin rises or falls by 20%. So you'll get a serial troponin measurement here. The guidelines have changed about CK&B, and that's why I've highlighted this in red on your slide, and that is CK&B has been removed from the guidelines. We no longer check CK&B. We want to check a troponin because it's more specific to that heart tissue. And then also the new non-ST segment elevation MI guidelines do say that you can check a BMP level to aid in diagnosis to ascertain the infarct size, and maybe an example of prognostically how well your patient's going to do. That typically is not what we go to. We don't typically draw BMPs, though. We see that more in heart failure presentations. So you're looking for a positive troponin, and you're looking for those EKG changes. Chest pain-wise, your patients may present all in the same manner. You cannot distinguish chest pain. You cannot use chest pain only as a distinguishing factor among the three subsets of acute coronary syndrome. Everybody's going to get early hospital care with MONA plus a beta blocker, and I'll talk about that in just a moment. But again, like I said, we're heading to the cath lab immediately within, and our goal is to reperfuse that artery or to do some type of intervention within the first 90 minutes. And that's easy if you're in a metropolitan area, if you're in a hospital that takes care of patients with cardiac disease, if you're in a hospital that has a 24-hour cath lab. Where it becomes complicated is if your cath lab is not open and you can't transport that patient to a facility that can open up that infarct-related artery. And that is when lytics come in. And so the most recent change to the STEMI guidelines say that if you cannot open up that artery in the cath lab, on the table, with PCI, which stands for percutaneous coronary intervention, then you can use lytic therapy, and actually lytics are preferred if you can't get that patient to a cath lab within 120 minutes. So that's when our lytic therapy becomes appropriate in STEMI patients. And if you are going to give lytic therapy, you have a goal or a performance measure of the time the patient has first medical contact to 30 minutes. So you have to make a decision fairly early. Am I going to transfer this patient to an outlying facility for a PCI, or am I going to give a lytic right now? So where my parents live, for example, in rural West Tennessee, they may be given a lytic if they present with their STEMI. I hope they don't have a STEMI, though. Those patients who present with non-ST segment elevation, we're going to do a little bit more digging. We are going to risk stratify them. Now, what I mean by that is we're going to look at risk factors that may lean our decision for more aggressive management in taking them to the cath lab. Do they have positive troponins? Do they have a high TIMI score? What's their GRACE score? And these risk calculators are available in your chapter as well as on the next slide. The point of those, I don't think you'll need to memorize these. I think you'll be given enough details in the case to say, aha, this patient's high risk, they need to go on to the cath lab. So and the goal of risk stratifying and maybe taking those patients on to the cath lab in non-ST segment elevation is we're trying to prevent a total occlusion from occurring, and we're minimizing complications. We're still giving them medical therapy, but in addition, we're taking them to the cath lab to see if we can intervene on anything and maybe place a stent. So the risk calculators are there for you. Again, I think that if you have a TIMI score that's greater than 3, or if you're given the details of a GRACE score that's greater than 140, those patients are going to benefit from invasive therapies. So we're going to put those patients high on our list to take them to the cath lab. The low-risk individuals are those without troponin elevation. They may have a GRACE score of less than 104, for example. These are the patients who might bleed more, and so we don't want to take that risk of taking them to the cath lab. But by far and away, most patients in every geographical area of the United States will be taken on to the cath lab. So there's new terminology in the non-ST segment elevation guidelines, and it's called an ischemia-guided strategy. What I want, that's just a bunch of words. It's the conservative medical management. We're not going to take these patients to the cath lab. We're going to treat them medically. They're going to get potent antiplatelet therapies, anticoagulant therapies, and we're going to wait and see. And if they have ischemia later on, ongoing chest pain, for example, then we'll take them on to the cath lab. But these typically are your very low-risk patients who we don't want to take, we will medically manage them first. This also includes females who are not troponin positive. We know that women in general have higher complications when we take them to the cath lab, and so we may choose in a non-positive troponin woman to medically manage her first and see how she does later on. The majority of patients, though, will go on for early invasive strategies, and that is we are going to take them to the cath lab. It's not like within the first 90 minutes like in STEMI, but these patients are also going to get antiplatelet agents and anticoagulant, and these are the patients who we feel are going to do better with some type of percutaneous coronary intervention or stenting. And it has been shown to be superior to medically managed patients in someone who's high risk. So again, those risk factors are the TIMI and the GRACE score, ongoing ischemia, chest pain, whether or not they have positive troponins or not. So let's apply this basic background information then to this case. This is a 66-year-old woman. She's got a past medical history of MI, hypertension, diabetes. She presents with sudden onset diaphoresis. Women present with atypical symptoms, not necessarily always with chest pain. Also, diabetic patients and elderly patients don't present with strict chest pain as well. She has nausea, vomiting, dyspnea. She does have chest pain. She does have pain radiating to her left arm, which is somewhat unusual for a woman. She has had a month prior her typical angina, but it's increased, or it's not brought on by much activity. So there is a change in her stable ischemic coronary symptoms. And her EKG shows that there is ST depression in leads 2, 3, and AVF. And then her troponins are positive. So what does this lady have? A non-STEMI, correct. She's on aspirin, Semva, metoprolol, metformin at home. She's given the diagnosis. You calculate her TIMI risk score, which is going to give you a level of 6. There's 1 point for each of the 6 distinguishers in that calculator. And so where's she going? Are we going to medically manage her, or are we going to take her to the cath lab? Absolutely. So the question in your chapter textbook, it asks this question: which is the best strategy for this patient? And before I even ask you to hold up some cards, I want to go through some basic, oh my goodness, that's not supposed to underline there, and that was not the right answer. Before I even ask you to comment on this, I want to just give you some basic test-taking techniques. And so the first thing about sitting for this exam is to critically review the question stem. So if it's asking you, what's the best antihypertensive treatment, and there's not an antihypertensive treatment as option, pay close attention to that, because sometimes with nerves we tend to overlook what they're basically asking, and we can can overthink a question. So this is asking for a best strategy. So I know there might be a taking them to the cath lab type thing in them. And then the second thing about examining your options are that often you can eliminate two of the responses based upon the details of the case, options that don't make sense. So particularly for the pharmacotherapy exam, look for drug interactions, look for contraindications that may make one of those options not the right response. And then when you get the question down to two choices, start to examine the differences between the two, and then hopefully you will have greater than a 50% chance at that point of getting that question right. So let's go back to this question. And so you see that everybody gets aspirin. So that's not a distinguishing factor. But what I've highlighted here is the are we medically managing or taking or waiting and seeing in this person, or are we taking her to the cath lab? We know we're going to take her to the cath lab. So we've automatically eliminated two of those responses. And now we're going to get into the nitty-gritty. We're going to talk about the drug therapy for acute coronary syndrome. Okay, so everyone, including our patient, is going to get early therapies, probably in the ER, while we're trying to decide what to do with them. Most patients will get an aspirin within the first 10 minutes. You need 162 to 325 milligrams when they first present, regardless really if they've been on aspirin before. And then patients will receive nitroglycerin, either sublingual, the spray, ointment, or maybe even a nitro drip if they're still complaining of chest pain. Most of the time we'll put on an anti-ischemic therapy such as a beta blocker. Oral beta blocker therapy is generally what is preferred. And this morphine, I want you to take note of, because this is not in the guidelines, but more recently over the past couple of years, some studies have come out to suggest that morphine slows the absorption of the antiplatelet agent that we are going to give. And this is very, very interesting because I think the guidelines will eventually change, where we may not be so free to give so much morphine early on because we know that we anticipate that patient is going to need oral absorption ability of their antiplatelet therapy. Still recommended by guidelines, but just note that that may be a moving target. So antiplatelet therapy and anticoagulant therapy is the crux of what you are going to be distinguishing among on an ACS case, most likely. And so there are two ways to make a clot. Either a totally occlusive clot or a partially occlusive clot. And there's a platelet pathway, and there is a thrombin pathway. And platelets this is in non-STEMI, the clot is very platelet rich. And so we are going to bring out all the antiplatelet tricks that we can. So everybody is going to get aspirin. Everybody will get a P2Y12 receptor antagonist. And some patients, those who are most high at risk, will get a GPI, a glycoprotein inhibitor. We'll talk more about these, but this is the global overview. So you may see up to all three classes of antiplatelet agents be appropriate for any given patient that presents with acute coronary syndrome. The difference in antiplatelets and anticoagulants is that you only choose one anticoagulant. So the anticoagulants that are available and generally recommended for acute coronary syndrome are unfractionated heparin, low molecular weight heparin. We have fondaparinux be appropriate in some individuals, typically those who don't go on to PCI, and then bivalirudin as well. So keep that in mind as you're looking through choices and trying to distinguish between answer options. We may give up to all three classes of antiplatelets, but you're only going to choose an option that has one anticoagulant in it. So this looks a little bit different than your table 3 in your chapter workbook, but I wanted to summarize the data for each agent based upon its place in therapy and the guidelines. And so your slide deck looks a little bit different from your chapter, but hopefully they coincide and you can follow that fairly easily. But everybody's going to get aspirin. You give an initial 162 to 325. Then you can go down to 81 milligrams a day after that initial dose. Aspirin has been the mainstay of antiplatelet therapy ever since we treated acute coronary syndrome. It reduces the incidence of MI and death, and that's why it is that's the first therapy that we give a patient when they present with their acute coronary syndrome. We know that higher doses are associated with more bleeding without additional benefit, so we stick to the low doses for maintenance therapy. And the only thing about enteric-coated aspirin, which is fine to take on a chronic basis, but when you're wanting quick absorption of an antiplatelet agent, you want to try to avoid enteric-coated aspirin in the initial acute presentation. Everybody's going to get a P2Y12. And there are 3 P2Y12 agents, oral agents, that are available if your patient is going on to the cath lab and going to get some type of percutaneous coronary intervention, a stent placement: clopidogrel, prasugrel, and ticagrelor. If we are medically managing those patients, so those are the low-risk patients, no troponins, they may have a patient preference not to go to the cath lab. For example, last week I had a 96-year-old who presented with a non-STEMI. He had positive troponins, but they said, no, thank you, we're not going to the cath lab. So we treated him with the ischemia-guided strategy. And so when you treat someone on that pathway, you're limited in P2Y12 options to clopidogrel or ticagrelor because of the data associated with their efficacy and benefit in ACS. Now, it's also, the guidelines also give preference to ticagrelor and prasugrel over clopidogrel. The reason for that, it's a 2B recommendation, so it's not class 1, but the reason for that is they're more potent antiplatelet agents. They are going to be more effective, but with that comes an increased risk of bleeding. And so specifically prasugrel has the caveat that it has to be used, if you're going to use it in preference to clopidogrel, it needs to be in a patient who's not already at high risk for bleed. And it needs to be a patient who's going onto the cath lab and PCI, because that would not be appropriate in a medically managed or an ischemia-guided strategy patient. Follow me so far? All right. So when a patient presents like ours did, 66-year-old female, non-STEMI, we're going to the cath lab, we have all 3 options that are at our disposal. They are class 1 recommended. So we have to choose now between these agents. And sometimes it's based on formulary. Like I work at the VA, we go to clopidogrel first in most of our patients. That's not wrong, but many institutions will do what the guidelines say in a 2B recommendation and go to ticagrelor first or prasugrel first in some individuals. That's not wrong, but sometimes we have to make differences. Our opinion, our choice needs to be based on contraindications or certain details of the case. And so that is where we're going to go through some differences that you may find useful when you're trying to answer a question in acute coronary syndrome. So first of all, you need to know loading doses. They're different for the 3. And so clopidogrel, with 600 milligrams, you're going to get antiplatelet activity within 2 hours. The other 2, a loading dose of 60 or a loading dose of 180 milligrams of ticagrelor, they're going to reach maximal platelet inhibition faster. They're more potent and their onset is quicker. Note that ticagrelor is given twice daily. And so when we talk about a patient who has adherence issues and they have received a drug-eluting stent, it becomes really important if we're going to choose a drug that's given twice a day versus once a day, because maintaining stent patency or keeping that stent open is very important, especially when we're counseling patients. It's very important for them to understand. Prasugrel is one that has a couple of different black box warnings. One is a consideration for those patients who are greater than 75 years, and the package insert will say use 5 milligrams daily in them. Although this was the dose that was studied in the Trilogy ACS trial, not showing a difference in outcome. And so this is more based on pharmacokinetics. They're trying to avoid a bleed in someone who's older, basically. And then someone who's very, very low weight as well can be recommended with prasugrel. Their metabolism is different. And this, by far and away, is the most common question that I get. And it's important. Clopidogrel is a prodrug. It is converted twice to its active form. Both steps of metabolism require some type of degree of CYP2C19 metabolism, and so therefore inhibitors of 2C19 are called into question. Now, I have cardiologists that say there is not a hill of beans different if you give a 2C19, if you give omeprazole or esomeprazole in these patients versus any other proton pump inhibitor. But there's observational data both for and against, saying that we really are not quite sure if this drug interaction makes clinical significance. Are patients experiencing stent thrombosis? Are patients not getting effectiveness of the drug? And I'll tell you that the only randomized placebo-controlled trial that addressed this issue was called the Cogent trial. Unfortunately, it was stopped early, therefore reducing the power of the trial to really give us a definitive answer. The trial actually showed no difference, but keep in mind that the results were underpowered. The details of the trial were underpowered. So what I typically do is tell my docs to follow the package insert. And in the package insert of clopidogrel, there is a drug interaction. There's a black box warning, and it says avoid esomeprazole and omeprazole, because they are potent 2C19 inhibitors. And I realize in the community that some physicians are going to not pay attention to that, but I want to point that out for you. The prasugrel is a prodrug, but it's not extensively metabolized by 2C19, so you don't have to worry about that same drug interaction. And ticagrelor is different. It's not a prodrug, so it becomes immediately active. And it also has reversible binding as well. So we run into issues with half-life because of surgery. Sometimes we get these patients into the cath lab and we think we're going to intervene on them with the stent, but then lo and behold, they have left main disease or they have some type of lesion that we need to go ahead and take them for cabbage. We can't stent that artery. And the hold time of these antiplatelets become very important. They're more potent than clopidogrel. Prasugrel needs to be held for 7 days to reduce the likelihood of cabbage-related bleeding, surgery-related bleeding. And ticagrelor carries the same holding time for elective cabbage. Now, for emergent cabbage, the guidelines do state that you can take a patient on to surgery if they're receiving clopidogrel or ticagrelor within the next 24 hours. So if there's an emergency situation, you reduce the risk of surgery-related bleeding by just waiting 24 hours if you can. All right, so that brings us to, let me say one more thing about the dose of aspirin. This is a black box warning in the ticagrelor package insert as well, and that is that you should limit your dose of aspirin to less than 100 milligrams a day. One of the reasons is because the North American cohort did not do as well in the Plato study that established its superiority to Plavix. They thought it was because we used 325 milligrams of aspirin more often than the other countries. It's interesting that it made that to the package insert, but that's there. I want you to be aware of that. All right, so this brings us to a new therapy that is available intravenously. It is the first intravenous P2Y12 receptor antagonist. It's called Cangrelor. It is direct acting and reversible. It's kind of like ticagrelor, if you will, in regards to it doesn't have to be converted from a prodrug to its active moiety. It's given as an IV infusion. As you might imagine, it's expensive. It's used short term, and it has a limited role right now because the earlier studies that looked at its effectiveness as compared to clopidogrel didn't show a difference. The Champion PCI and the platform trials showed no difference. So why would you use an IV therapy if you had your oral option available? You probably wouldn't. The Champion Phoenix trial, which was done a few years later, actually did show better efficacy with Cangrelor than starting an oral load of clopidogrel. But that came with the caveat that it increased bleeding. So it's going to be more potent. It's also going to carry an increased risk of bleeding. And again, why would you use it if you have an oral agent available? Well, one reason is that it might be that your patient can't take oral meds, so maybe you could use it in that setting. Or In patients who are going on to CABG in that 5-day interim, let's say they have ongoing ischemia, they have chest pain, they need an antiplatelet agent. We might use Cangrelor as a bridge to CABG. We can cut it off. Within a few hours, the antiplatelet effect will be gone, and surgery can be safely proceeded with. Interestingly, and I think this is really important for the exam, if they start asking you questions about Cangrelor, keep in mind that it has never been compared to someone who's receiving prasugrel or ticagrelor. So the newer antiplatelets, it has never been studied against. So it has only shown a greater efficacy in someone who's receiving clopidogrel. And in that person who receives clopidogrel, that was only given at the time of the cath or the time of the PCI. It was not a preloaded person or those patients who received clopidogrel prior to the cath lab. So keep that in mind as well. And a very important drug interaction, and this is unusual, but clopidogrel and prasugrel cannot be given while a Cangrelor infusion is ongoing. You have to wait until after the Cangrelor infusion is turned off before clopidogrel and prasugrel can be given. Ticagrelor has no drug interaction associated with Cangrelor, so they could both be given at the same time. And really, what it is it has to do with the reversible, the non-competitive binding of both of those agents, Cangrelor and ticagrelor. And whereas the ADP antagonists, the clopidogrel and ticagrelor, sit on a certain part of the ADP receptor, that's not an issue with the other two. So there's no drug interaction in between Cangrelor and ticagrelor. A cost analysis is probably forthcoming. It is expensive. I know the last time we looked at a patient who needed it for bridge therapy to CABG surgery. This was just a couple of weeks ago. It's $500 a vial and ended up being thousands of dollars a day wait time. So everybody's going to get aspirin. Everybody's going to get a P2Y12. Some patients may get a GPI. And it's important for you to realize the historical background of GPI therapy. Most of the GPIs that were studied showing a difference in outcomes, so reduced MI, reduced need for revascularization, the composite of a reduction in death, were in a setting where we did not routinely stent everybody. We stent everybody today. We're also in an era where we did not use routine P2Y12 receptor antagonism. And now that we have those modern therapies, the most recent GPI trials have not shown necessarily the benefit that the earlier trials did. So the guidelines are going to put, they have limited use. It's in a very high-risk patient who has not been treated with upstream P2Y12 receptor antagonism. And it's in a patient who is most likely treated with unfractionated heparin, bringing the anticoagulant. So the guideline actually says not treated with bivalirudin, but it's those patients who are treated, if you choose unfractionated heparin, GPIs are a great option with that if you have patients with high-risk features who have not been adequately pretreated with the P2Y12. Your preferred options are the smaller molecules, eptifibatide and tirofiban. Note that these two molecules are renally cleared, and this is an update both in your handout and your chapter. I need you to put a star here because the new dosing of tirofiban in ACS includes a creatinine clearance less than 60. It used to be 30. You are going to reduce the dose of the infusion by 50%. So just know for the exam that both of these agents are renally cleared, and you're going to need to reduce the dose of the infusion, not the bolus, but the infusion, when creatinine clearances fall less than 60 for tirofiban and 50 for eptifibatide or integralin. Okay, so this is where, this is just a pictorial of the guidelines. So this is where our patient fits in. Okay, so everybody's going to get aspirin. She's going to get aspirin. Everybody's going to get a P2Y12. And then we are also going to consider maybe a GPI in her because She's high risk. She's positive troponin. We haven't uploaded clopidogrel yet in her, or ticagrelor in her, so we might consider a GPI in her. And then the question then becomes, where are we going to go with anticoagulant therapy? And so everybody gets one anticoagulant, and based upon how that patient presents, you're going to choose which anticoagulant has the best data. So for example, if you are going straight to the cath lab in STEMI, the STEMI guidelines will say either choose unfractionated heparin or bivalve. If you are giving a lytic, if you're in the rural community and you can't get to the cath lab, it changes. It becomes unfractionated heparin and enoxaparin and fondaparinux, because those have been studied with fibrinolytic therapies where bivalve has not. If you are taking them to the cath lab to see the anatomy, to see if you can intervene on that patient, then all four become class 1 options. And then when you're medically managing a patient, note that bivalirudin is not an option according to the most recent non-ST segment elevation ACS guidelines. So let's just talk briefly about each anticoagulant. Unfractionated heparin's the gold standard. It was the first available. The dose is 60 and 12 as opposed to 80 and 18 that you see for DVT-PE. And you're going to monitor if you use this agent and APTT on the floor, you might see an ACT or an activated clotting time being monitored in the cath lab to see if the patient is anticoagulated for the cath. And you generally will continue this for 48 hours or until something is done in the cath lab. If we intervene on that artery, place a stent, for example, we'll stop heparin after the case. Low molecular weight heparins can be used also. The dose is 1 milligram per kilogram Q12 in non-ST segment elevation ACS. In STEMI, you want to achieve therapeutic levels very quickly, so you're going to give an additional 30 milligram intravenous bolus. And maybe you might do that in some select non-ST segment elevation patients, but mainly that's for STEMI. Keep in mind that enoxaparin is renally cleared, and therefore the dose may reduce down to once a day in those patients whose creatinine clearances fall below 30. Enoxaparin can be used in the cath lab if your patient received the last subcutaneous dose 8 to 12 hours ago. You're going to give them a tiny little bolus just so they're anticoagulated for the case. So you give them a 0.3 milligram per kilogram bolus just for that, the reason of making sure they're anticoagulated during the case. If it's been 12 hours since their last subcutaneous dose and you're taking them to the cath lab, you treat them as if they're naive to anticoagulants. So we would just use heparin in those individuals because it's easy on, easy off. And then some individuals will use a loading dose if they choose enoxaparin to go onto the cath lab. Fondaparinux is interesting. It has been shown to be superior as far as bleed rates go in acute coronary syndrome to enoxaparin, but its use is limited. It's probably because of its mechanism of action. It's a selective inhibitor of activated factor 10, and so the patients who were in the OASIS trials that went on to the cath lab had catheter-related thromboses, meaning you're affecting 10, but you're not affecting 2. We're still having thrombosis with this agent, so therefore we're going to have to use another anticoagulant when we take them to the cath lab. So fondaparinux falls out of favor in most centers that have a 24-hour cath lab because it essentially is a second anticoagulant that that increases a patient's risk for bleeding. You have to give heparin if you are placing a stent in someone who received fondaparinux before. So that becomes a class 3. It's actually harmful for patients who go on to PCI. Again, though, if you're not taking them to the cath lab, fondaparinux is quite appropriate and can be used. It's the dose of 2.5 milligrams daily, and it also is renally cleared, so it's contraindicated when patients fall below, their serum creatinine falls below 30. Bivalirudin is the last option, and it is an anticoagulant that's used very commonly at the hospital across the street from me. It is one that has shown a reduction in bleeding in comparison to an unfractionated heparin plus a GPI approach. So again, some of this is formulary specific, but you may see any number of these anticoagulants being given on the exam. Okay, so we're back to our question again. An early invasive approach we know. Now I'd like to see your cards to see which strategy you think might be best given the details of the case. And I see lots of blue, which is correct. We want clopidogrel. We want a P2Y12. GPI is certainly appropriate in her. And the option B is just not as optimal because we're not treating her as efficiently as we could given the details of her case. So option A is correct. This is the bottom half of the algorithm that appears in the non-ST segment elevation MI guidelines. And so this is where we've already looked at her anatomy. And now we're going to decide if we're going to intervene with a stent, PCI here, or if we're going to take her to cabbage. And so in this instance, know the different agents that become appropriate now. You're committing to stenting this patient. Prasugrel becomes an option as a P2Y12 agent, and fondaparinux falls out. It is not your preferred anticoagulant. So those are the basic differences between the anticoagulants in this regard. Okie doke. So moving on, we're going to talk about the duration of dual antiplatelet therapy if you place a stent. So this is a woman who's received an elective PCI, and so which option represents the length of therapy that this patient should receive dual antiplatelet therapy? I kind of want to see colors on this one. Okay, so lots of D's, some different colors. So let's talk about what the new guidelines, hot off the press, say about the length of dual antiplatelet therapy. So first of all, aspirin 81 is given indefinitely in everyone who presents with an ACS or anyone with coronary disease who receives a stent. And it's reasonable to use 81 milligrams. If you have a patient who presents with an acute coronary syndrome, it is 12 months, regardless of whether or not that patient got a stent. Okay? It's the patients who get an elective PCI where the guidelines are changing. And this is not in your chapter. It is not in your slide book. This was presented at ACC last week, so this is brand new, hot off the press. And basically, it's very hard to read, and I get that. You can Google it. It has not been published in print yet, but the DOI is on this slide for you. But you can just Google 2016 ACCHA duration of dual antiplatelet therapy, and it will come up. But basically how they divide this is whether or not the patient presents with an acute coronary syndrome. And you note that this is 1 month, 6 months, 12 months. So everyone who presents with an acute coronary syndrome is going to have dual antiplatelet therapy for 12 months. This is regardless of whether or not they get a stent. It's those with stable coronary disease that the duration is changing. And the rationale is based upon the generation of stents that we're using now are not as thrombotic, and so we can get away with less time of dual antiplatelet therapy. And the reason, remember, it's very important, the reason we're using dual antiplatelet therapy is to not reduce risk for death. It's to reduce risk from it's to reduce the risk of stent thrombosis. And so now we're at a time where we may, if a drug-eluting stent is placed, and it used to be 12 months, you can get away with a shorter period of time, maybe 6 months, as long as that patient was elective, it wasn't an ACS. And of course, they're giving the caveat here that you can choose to utilize dual antiplatelet therapy for longer. So when in doubt, choose 12 months, but the latest guidelines are suggesting that we can get away in stable patients with a lesser period of time. And so for those of you who chose at least 12 months, that used to be the case. Now this is an elective person, and so it could be C in this based upon the latest guidelines. And 1 month is appropriate for bare metal stents, not for drug-eluting stents. All right, so last case in ACS, and then we're moving on. This is a patient who presents to a major teaching hospital and crushing 10 out of 10 substernal chest pain. They have ST segment elevation in leads V2 and through V4, so this is indicating an anterior STEMI. The diagnosis is made. And so what is best to treat this patient? I'm seeing a few A's. Anybody else want to guess? Still A's, you're right. This is the patient that you want to get to the cath lab within 90 minutes. They present to a major teaching hospital. So you assume at a major teaching hospital that they have a cath lab that is open and available. The other options include lytics, which do not become, the tenecteplase and retiplase do not become appropriate until we know that the cath lab is down and we can't get them to another cath lab within 120 minutes. And this would just not be appropriate because we need to do something. Option D is lacking either primary PCI or some type of fibrinolytic therapy. In your handout is included relative and absolute contraindications and the 3 lytic agents that are available. Keep in mind for the exam that and in clinical practice, far and away, we're going to take them for primary PCI to the cath lab. And these lytics have, it's been so long since I've seen a lytic be used for acute coronary syndrome because of modern abilities to intervene on that artery in the cath lab. But keep in mind that the dosing is different for stroke. So you want to pay attention to that on the exam. It's different for when you're thrombolysing a PE than the dosing used in acute coronary syndrome or STEMI. All right, and in a STEMI patient, I highlighted this before, but just keep in mind that when you're taking that patient, this guy that presented with 10 out of 10 and ST segment elevation, you're going to choose either unfractionated heparin or bivalirudin as your anticoagulant of choice. So A is correct. All right. I'm going to skip through the basic secondary prevention guidelines or secondary prevention meds for the sake of time. You guys should know these. Some of this information will also be covered by Dr. McConnell because everyone who's post-MI is going to get the evaluation. It's 6 meds, okay? So everybody gets aspirin plus a P2Y12, beta blocker, ACE inhibitor, high-dose statin, and then plus or minus spironolactone based upon their EF. And she will cover that when we talk about chronic heart failure. So I'm going to skip through these slides, and they are there for your reading. And we're going to move on to acute decompensated heart failure, which is also very common in my practice. And it's the number 1 DRG. Heart failure is for those who are aged greater than 65. One of the most common reasons for patients to present are either dietary non-adherence or drug non-adherence. And so pharmacists play a huge role in helping those patients understand the benefits from their chronic heart failure medications, which Dr. McConnell will cover. But I want to say one word about the BMP and its place in the guidelines, and that is it is useful as a diagnostic tool. It is useful as a prognostic tool. But you cannot you can't treat a lab value. You have to look at the patient as well. And the patient is still going to give you symptoms that are very important to drug therapy and diagnosing their stage of heart failure and what we're going to do. So on a given case, you will be given either symptoms of a decompensating heart failure. There are 2 types. You want to ask yourself this question: does your patient have symptoms of congestion at rest? Those symptoms include dyspnea on exertion, PND, orthopnea, rales, and the list goes on. These are examples of too much volume. And then you also want to ask yourself, is this patient experiencing signs of hypoperfusion? And so in these patients, they may be fatigued, they may have a low blood pressure, they may have mental status changes, they may have cold extremities or a narrow pulse pressure where the gap between the systolic and the diastolic blood pressure kind of tightens. These are signs that your patient is hypoperfused. And we are going to initiate drug therapies based upon these symptoms, and they're different. And you may also be lucky enough to be given hemodynamic parameters on the exam. Now, in clinical practice, we don't put pulmonary artery catheters in everyone. And so we have to base our decision on their symptoms. But on a case, you may be lucky enough to be given numbers. And so for that reason, I'm going to go through just a few of these. The pulmonary capillary wedge pressure is the first number that you'll want to pay attention to. This indicates volume. How much congestion does your patient have? And so for a normal person, they may have a pulmonary capillary wedge pressure of 8 to 12. It's not unusual for someone with heart failure to have 15 to 18 as their normal. But it's not unusual if you have patients coming in with decompensation to have a pulmonary capillary wedge pressure between 20 and 30. That's common. That's indicative of volume, and we're going to give diuretics if someone has a high pulmonary capillary wedge pressure. The other number to look at is the cardiac index, and these two are kind of related. Your cardiac index is your cardiac output divided by your body surface area, and because most of us have a body surface area of 2, roughly 2, it's usually half your cardiac index. The number you're looking for is 2.2. You want a cardiac index of above 2.2, meaning you're perfusing vital organs. And then the SVR is the last number. The SVR is indicative of your afterload, and it basically means that there's circulating levels of neurohormones that are circulating in the bloodstream. How much angiotensin II, how much vasoconstriction occurs, and it's very common for heart failure patients to have high SVRs in early heart failure. In end-stage heart failure, you might see numbers that are down here in the 800s, and those patients go on for LVADs and transplants. These two equations, which I also think you learned in your critical care module that was presented yesterday, become very important. So if you remember, your blood pressure is equal to your cardiac output times your SVR, and your cardiac output is your stroke volume times your heart rate, you will know how to treat any acute decompensated heart failure patient. And your stroke volume depends upon several factors, the innate contractility of the heart. So, for example, do you have dead tissue or do you have viable tissue that can be salvaged? How much afterload, how much SVR are we pumping against, and how much volume is on board? And keep in mind that sometimes, although it's rare, you can have a patient experiencing heart failure symptoms because they're not on the Frank-Starling curve at all. And on occasion, if in hypovolemia, for example, we may need to give just a little bit of fluids so that their filling pressures are adequate for them to have a cardiac output. So you can have heart failure decompensation at very low volume and very high volume. So when you ask yourself those questions, is my patient experiencing symptoms of congestion at rest? If it's no, they're on the left side of the quadrant here, and if it's yes, they're on the right side of the quadrant. And whether or not they are hypoperfused, if you have numbers, anyone who's less than 2.2 is down here, or anyone with those symptoms are below. And we're going to base our drug therapies on which quadrant those patients present to. So we're going to use diuretic therapy when they are fluid overloaded. We may use vasodilators when they are having pulmonary symptoms and sometimes even symptoms of hypoperfusion. We may go to a vasodilator. And then we'll use inotropes when patients require, when their blood pressure is too low and cannot tolerate a vasodilator and they require some increase in contractility. Just note, none of these therapies increase or decrease mortality. These are more therapies that we are giving to treat that patient in the moment, but there is no value in any of these long-term wise. These are generally short-term therapies just to get them through their exacerbation. And speaking of that, I want to make a note that when a patient comes in with an acute decompensated failure, we are not going to stop their ACE inhibitor, their beta blocker, particularly their beta blocker, if we can help it. The rationale is because we know that when we remove these therapies that address the neurohormonal complications that are ongoing in heart failure, that those patients tend to do worse later on, and we don't get them back to their targeted dose as quickly or as often. as we would if we had maintained therapy. Now, the caveat here is certainly if you have patients in cardiogenic shock or if you have patients in acute kidney injury, you're obviously going to have to stop their ACE inhibitor and their beta blocker. But we try to keep those chronic meds ongoing in a decompensated state if we can. Just a couple of cautionary things. ACEs and ARBs can cause acute kidney injury. And we may down titrate the dose during an exacerbation. We definitely don't want to up titrate their beta blocker during a decompensation. So that's not the time to push until they're euvolemic and they're in a more stable state. And caution with DIG only because some of these patients will have bumps in their serum creatinine, and obviously DIG is renally cleared. So this is a 72-year-old male. He's admitted for heart failure symptoms. He used to be able to walk 30 feet. Now he can only walk 10. He used to sleep on 2 pillows. Now he sleeps on 4. He's got 3+ pitting edema in his extremities. He's gained 30 pounds, and he admits to dietary non-adherence. He's got an ischemic dilated cardiomyopathy. His EF is 25%. He's got AFib, hyperlipidemia. He looks like everybody I see on service every day. His pertinent labs, you do have a high BMP. You've got a serum creatinine of 2, but his baseline's 1.9, so that's not impressive at this point. You have a blood pressure that is manageable. We can work with a systolic of 108. You note that his O2 sats are 95%, so he's not in dire distress, if you will. And his home meds, you look and he's on an ACE inhibitor, a beta blocker, spironolactone, DIG, which would all be appropriate for the chronic management of heart failure. So what's the best regimen right now for treating his acute decompensated heart failure? And many of you are already choosing the right answer, but we're just going to talk about this. What quadrant does he present to? This is quadrant 1, this is quadrant 2, this is quadrant 3, and this is 4. He has signs of congestion, so he is wet, and he does not have signs of hypoperfusion, so he is warm, so he presents in quadrant 2, and that is where we're going to utilize diuretic therapy. The guidelines also say that we can use vasodilators here, and I'll talk about that in just a minute. But before that, I want to talk about when and what type of diuretics we use. So IV loop diuretics are recommended, and certainly you can also try to fluid and sodium restrict these guys. It's very hard to do. You can increase the dose or give a continuous infusion. So you can give IV boluses or continuous infusions. It doesn't matter of a loop diuretic. The dose trial showed no difference between those two strategies. You can add a second diuretic when a patient has diuretic resistance, if you will. Generally, it's a thiazide type diuretic that is added. You can use hydrochlorothiazide if you want to, but metolazone is generally one that my docs go to more so than others. And another strategy to overcome diuretic resistance is ultrafiltration, although it has not been shown to be any more beneficial than any of the other strategies. So the difference between these two slides, I just want to point out, the slides that look like this, that say guidelines, those are the Heart Failure Society of America guidelines. And then I've also given you the slides that look like this with the classes and level of evidence are the ACC AHA guidelines. They basically say the same thing. But I wanted you to see the differences in wording, and so that's provided for you in your handout. And basically, when someone comes in with heart failure symptoms in quadrant 2, we're going to choose an IV loop diuretic, and we're going to probably double the dose. So generally, we'll go to 2 to 2.5 times what the oral dose is. And remember that oral furosemine's bioavailability is half of what IV is. And so 40 milligrams of Lasix PO is equal to 20 IV, but the other two loop diuretics, bumetanide and torsemide, have 1-to-1 bioavailability, and so their equivalency is 1 milligram to 40 oral, and 20 to 40 of torsemide is equal to 40 of furosemide. Loop diuretics, particularly the one that I see most common is Lasix, and it will have a ceiling effect. We very rarely go over 120 milligrams because you don't get more benefit, but you get more risk for adverse events associated when you go above and beyond that. we typically will go to a second diuretic if we can't control their symptoms with 120 milligrams of Lasix. Chlorothiazide is a thiazide that's given IV that can be used, particularly if you're worried about gut absorption. And it's expensive, though. It's, last I checked, we don't use it often, but $250 to $500 a vial, so it's not cheap. And then the hospital across the street from me uses a continuous infusion. So if you're going to use that dosing strategy, you start at 1.1 milligram per kilogram per hour and then double the dose every 4 to 8 hours with a maximum dose of 0.4. So all of you were beginning to choose the right answer, and that is we're going to use Lasix in this patient. So let's progress just a little bit. We start with IV Lasix, and now the serum creatinine has bumped to 2.7. The potassium is 5.4, and he is transferred to the CICU for diuretic refractory acute decompensated failure. It's important to note that his O2 sats are now dropping, so he is experiencing acute pulmonary edema, and we're going to start to be concerned about this patient. We're going to give an IV dose of chlorothiazide to try to increase absorption of that diuretic to reduce preload, because his symptoms are related to that acute pulmonary congestion. And note, though, that his blood pressure is still stable, and so we don't think he's hypoperfusing yet. But this is the time when we are going to go to IV vasodilator therapy. And we're not ready for the inotrope yet because he's not hyperperfusing. But the vasodilators can be used in settings of acute pulmonary edema here, where we're trying to avoid an intubation. And based upon their mechanism of action, we can also use some vasodilators when we have some symptoms of hypoperfusion, as long as we have blood pressure to work with. So in this patient, because he does not have symptomatic hypotension, we're going to go to a vasodilator first. So the guideline differences, basically, I mean, they're the same thing. When you have blood pressure to work with, you're going to go to a vasodilator before an inotrope. But the caveat is that if your patient has preserved ejection fraction, you may want to be very careful with IV vasodilators. But most of these patients that I have been referring to in the guidelines are talking about those that have reduced ejection fraction. So you consider vasodilator therapy to rapidly improve symptoms. Now, which vasodilator, based upon the mechanism of action, is more venodilating than arterial? Which one is going to be more likely to reduce symptoms rapidly from the pulmonary side? Nitroglycerin. It is more venodilating than arterial, so it's affecting preload more than afterload. And with higher doses, you can get some afterload reduction with nitroglycerin, but this used to be a mainstay of therapy in the ERs when patients would come in with acute decompensated failure and congestion that was not able to be controlled relatively quickly with diuretic therapy. Nitroglycerin is one that we also can use in patients who present with acute heart failure with hypertension, those types of things, as well as ACS. The other two, nitroprusside and Recertification, are different. They're basically balanced, mixed venous and arterial vasodilators. And again, there's never been really evidence that any of these vasodilators are going to improve mortality in this setting, but you choose the vasodilator based upon what is safest for the patient and what makes the most amount of sense. So based upon the pharmacology, for example, nitroprusside, we know that you've got risk for cyanide toxicity, and at least at my hospital, it requires a pulmonary artery catheter to be placed if we're going to use nitroprusside, because you can really drop blood pressures very quickly, and it has to be very tightly monitored and controlled. It does have a short half-life, so that's an advantage. Recertification has kind of fallen out of favor because of its cost and the long half-life and no advantage over the other two. But it's also a balanced arterial and venous vasodilator as well, and it can be used. It does not require renal or hepatic adjustment, which nitroprusside would. So as long as you have blood pressure to work with, go to a vasodilator first. So which option would you choose in this patient? You can eliminate 2, and so now it's down to A or B. Everybody's choosing A. You're avoiding the sodium nitroprusside because that's a dose that may not be renally adjusted for this patient with a serum creatinine of 0.9, and I agree with you. All right, so the patient initially responds to nitroglycerin, and then overnight, though, and over the next day, a couple of days, they have decreased urine output. The serum creatinine has now risen to 4.3. He's cool. His extremities are cool. He's drowsy and mentally confused. And so now you're in a situation where you are either going to consider putting a Swan-Ganz catheter in, or you're going to automatically assume that he is hypoperfused, and you're going to go ahead and start treating him with an inotrope. Artery catheters are not used as commonly as they used to be. They're not recommended first line, but sometimes we'll put one in if we're not sure if we've been too aggressive with their diuresis. So let's say, remember the Frank-Starling curve that I showed you? So if a patient, if we've been too aggressive with his diuresis, maybe he is now hyperperfused because he doesn't have adequate filling pressure, so he may not have enough volume on board. So artery catheter monitoring, I hope they will give you on the exam. And you're lucky in this case because you're given that information. His pulmonary capillary wedge pressure is 30, so that confirms that we did not overly diurese him, and he is not hypovolemic. And his cardiac index is 1.5, so as we suspected, he is hypoperfused. And because of that, he is going to need which therapy? Okay. I'm seeing some A's and some B's, which are, if you were able to narrow it down to 2, those were the 2 appropriate. Now let's talk about this for just a second, because this is the controversy that my docs have all the time. And I have one doc who is very old, bless his heart, and then I've got one who's very young, and they have very different opinions about how to manage this disease state. Well, that's interesting. That just twirled my question. Not supposed to happen either, Brian. Come on, man. Okay, so now we're thinking that this patient is in quadrant 4 because we know that he has a high pulmonary capillary wedge pressure as well. And so when we get to quadrant 4, we're going to use inotropes. If the map falls too low, though, we're going to have to use dopamine or some type of vasopressor in this instance. And so inotropes are generally helpful in patients who present like he did with diminished organ function and don't have adequate blood pressure because we can't use a vasodilator. Sometimes we use them in patients who have so much fluid overload and they're not responding to diuretics, and we occasionally use those to increase renal perfusion as well. The difference between the two, it's a preference. There have never been true head-to-head comparisons between dobutamine and milrinone that are prospective. Dobutamine tends to have more arrhythmias associated with its use, according to the ADHERE registry and observational data. Milrinone obviously is renally cleared, so you have to be very careful about renal adjustment with milrinone. Milrinone is also more vasodilatory, and it can affect SVR. And in my experience, most of the patients who we see have a high enough SVR, and this patient did, that they will tolerate. Remember, your blood pressure is equal to your cardiac output times your SVR. Generally, if we dilate that and their SVR goes down, we get a compensatory increase in cardiac output. So milrinone is my preferred agent, also because this patient is on a beta blocker chronically, and I want to keep them on that beta blocker. And if I use dobutamine, what's the use in giving a beta blocker and a beta agonist? You have to that doesn't make sense. You have to use higher doses of dobutamine to overcome the blockade that he's already receiving. So there are differences in these. Keep in mind that milrinone does have a longer half-life, and it can cause thrombocytopenia, so that's an unusual side effect that can, you want to monitor CBCs with that agent. So of these two, really, I've got one doc that would choose dobutamine, but then I have to stop their beta blocker. I would go for milrinone in this patient. It is renally adjusted. We don't give a bolus. And so that is my preferred option in this particular patient. One word about inotropic support. We know that oral inotropes, when they were studied, increased mortality. And so the general philosophy of using inotropes in someone is to use the smallest dose for the shortest amount of time. There are some patients, though, who are end-stage disease that will die if we don't increase perfusion in them. And those patients are generally evaluated for transplant, or they're evaluated for an LVAD. And these are the guys that may use their inotrope as a bridge therapy until they get their device. And this starts becoming very subspecialized, and we're not going to talk about mechanical circulatory support. But I want you to realize that ideally we're not using long-term inotropes in anyone. They're class 3, but we may see a need to bridge them until we can support them otherwise. Vasopressin antagonists might come up on the exam. This is very, very limited. Sodium, low sodium is a prognostic factor for death in patients with heart failure. Tolvaptan has been approved. Generally, the hyponatremia that tolvaptan reverses comes back after you stop the drug, and because of risk for renal impairment, the FDA put a 30-day, you can only use it for 30 days. So this is very, very limited, but it is an arginine vasopressin antagonist as well. All right, we're moving on. We're going to talk about acute ventricular or acute life-threatening arrhythmias, the things that we would see in the hospital. Dr. McConnell will talk about the things that you might see in the clinic setting, the atrial fibrillations. I'm going to talk more about ventricular or the acute settings that we would take care of quickly. And I must mention that the BLS and the ACLS guidelines have recently been updated in October of last year. And how many of you are BLS certified? Okay, so many of you may have taken your online training that was due by February 15th to get you current with the new guidelines. So some of this will be very repetitive for you. What about ACLS? How many of you are ACLS? Fantastic. So we are now just getting our new teaching materials for both BLS and ACLS. And so let me just briefly talk through the new BLS guidelines have new chains of survival for a patient who presents with in-hospital cardiac arrest and out-of-hospital cardiac arrest, recognizing that those in the out-of-hospital setting will need EMS transport. They may need an AED, as those patients in the hospital are taken care of more quickly. There's also, interestingly, we've gone away from listening, and feeling to simultaneously looking for and assessing for both a pulse and breathing. And this minimizes the time that we take away from high-quality CPR. So this is very important. As you learned in critical care, I understand that he covered some of this as well. It's still CAB. It's still 30-2 for healthcare provider. And for those of you who teach BLS, in the Heart Saver AED course, they teach compression only CPR because of the data that suggests that compression only CPR is not any worse than providing 30 compressions to 2 respirations. And so for those in the community that are not healthcare providers, they feel very comfortable with hands-only CPR. The depth has changed to indicate a higher limit of normal, so it's 2 to 2.4 inches. The rate has now been changed to 100 to 120 beats per minute, and you want to allow for adequate chest recoil so there's no leaning on the chest. And there's this new term called chest compression fraction. You probably won't be asked a question on the exam about that. That's basically the time that you're giving compressions versus the time that you're not. And they want that, although there's not an optimal number, basically they're just saying you want 60 or more % of the code situation to be giving compressions, ideally more than that. There's also a change that in the community for an out-of-hospital cardiac arrest, we used to, if an AED was arriving, or we were waiting for an AED, it used to be that you would give one cycle, a 2-minute cycle of CPR. It's been shown now in trials that we will shock as soon as the AED is available. If you're waiting on an AED, there's no problem in giving compressions, but don't do a 2-minute cycle. Go ahead and shock first. Also, if there's an advanced airway, it's been updated. It used to be 6 to 8 seconds, and now you provide a breath every 6 seconds. What's interesting is naloxone has been approved now as a part of BLS. So we're teaching people in the community about using this as VO. And it is because, congratulations, the United States is so fantastic at opioid overdose. They are now including a reversal agent in basic BLS training. This delivers 0.4 milligrams of naloxone to the patient. You administer it in the outer aspect of the thigh. The device that is in the AED kits that are, or if you have access to this medication, will make a hissing sound when it is administered. That is just a sign that it's done what it's supposed to do, and then the needle will retreat. So it's very easy for someone in the community to give this. It's not a nurse or a pharmacist required administration. Vasopressin has been removed from the guidelines. So now, in the 2 algorithms that are the most life-threatening, we no longer have to decide between epi and vasopressin. It is just epi. And so we have a shockable rhythm and we have a non-shockable rhythm algorithm. And in the non-shockable algorithm, that's PEA and asystole, we want to give epi as early as possible. So no more 2-minute cycle of CPR before you give a med. Just as soon as you're recognizing that it's PEA and you're thinking about reversible causes, you can go ahead and give the epi. The reason is one large trial has shown that the earlier the epi administration, the better, as opposed to delayed administration of epi. And then the guidelines also say that steroids in an in-hospital cardiac arrest are reasonable. They don't give them a class 1, they don't give them an appropriate recommendation, but because of what we've seen of their benefit in sepsis, and it's a similar situation that steroids are reasonable if they can be given in an in-hospital cardiac arrest. So these are the 2 shockable rhythms, our algorithm for pulseless VTAC and VFib. Please note that high-quality CPR and defibrillation are the treatments of choice here. You're going to shock first, give 2 minutes of CPR, shock a second time if they're still in that rhythm, then you give your epi. So after shock 2, you give your epi. Then you're going to do 2 minutes of CPR as well. Check again. If it's still pulseless VFib, VTAC, you will defibrillate again with shock number 3, and then that is when you can consider an antiarrhythmic, amiodarone being the preferred 2B recommendation there. Lidocaine can be used if amio is not available, but we want to go to amio in this case. So really it's only 2 meds that you need to be aware of in the life-threatening arrhythmia algorithm. PEA is the non-shockable rhythm. We're going to go ahead and assess our patient. We're going to give epi early, 1 milligram every 3 to 5 minutes. We're going to think about our reversible causes, the 5 H's or 6 H's and T's. And if at any point in time that rhythm converts to a shockable rhythm, we go to the other algorithm. I know that also in the critical care module, you were taught targeted temperature management, and that is the case. Anyone who has survived one of these 2 algorithms, hypovolemia, or I'm sorry, my goodness, pulseless VFib VTAC or the PEA asystole algorithm, that is comatose, but they have return of spontaneous circulation, are good candidates for therapeutic hypothermia or targeted temperature management. And he shared with you some techniques on reducing shivering and adverse events that occur from the hypothermia. Okay, I want to time out. Everybody take a deep breath. Okay, you're through a lot. We've just got a few minutes left that I want to talk about ventricular arrhythmias and other non-life-threatening arrhythmias, because in the ACLS setting, you not only have the 2 algorithms that are shockable and non-shockable, but you also have rhythms that occur when a patient is inpatient and you still have to treat those. But before we go into that, I kind of want to do a debriefing. We're going to go back to basic pharmacology, and we're going to remember all the antiarrhythmics that are at our disposal, okay? So we have the Vaughan Williams classification, and I think the most important thing that you need to understand going into this exam is that, number one, this should not cause angina, okay? You should not feel chest pain when you see an antiarrhythmic. What I'm going to do is try to teach you something very easy for you to remember. But you need to understand the clinical utility of the agents. And you see from class 2 to class 4 that all of these can be used for both atrial and ventricular arrhythmias. So they're at our disposal for both types of arrhythmias. Whereas the class 1 or the sodium channel blockers have a variety of different uses based upon their mechanism of action. So for those of you who know me, and there are a few of you in the audience, my favorite meal in the world, I mean, if I know I'm going to have a last meal, it's going to be a burger. I'm an all-American girl. So everybody look up here really quickly. Double quarter pounder, mayo lettuce, more fries, please. And, you know, Marizicine's not available, but I always like more fries, so it's in there because I can remember my mnemonic. But you can put an X through that, Marizicine. So, double quarter pounder, lettuce, mayo, more fries, please. So we're going to talk about the 1A because their clinical utility is different, and you need to understand this going into the arrhythmias that we're about to talk about. So the 1As, the double quarter pounder, are both effective for atrial and ventricular arrhythmias. And they're not used very often in clinical practice today. One of the reasons, and look up here real quick, is torsades. They cause acute decompensated heart failure. So the adverse events of these agents don't often outweigh their benefit. And in particularly, we do not use them in anyone who's post-ACS because we know that they increase mortality in those patients. So these are easy things that you can look for in a patient case to kind of eliminate those. Also, they have drug interactions associated with their use. And so they are not optimal clinically because of that. Oh, the only one that might be that I see sometimes a patient will have a PSVT that's vagally mediated, and because disopyramide has anticholinergic side effects, it tends to be used for that particular arrhythmia. Your class 1B agents, these have little affinity for the atrial tissue. So they're used mainly in ventricular arrhythmias. These are easy. This is lettuce mayo. So lidocaine is the IV, mexilatine is the oral. They have to be adjusted, or lidocaine has to be adjusted for renal and hepatic impairment. Mexilatine can cause CNS side effects. Actually, they both probably can. Mexilatine I see very, very rarely in someone who might already have a device like an ICD and we're using it with amio to decrease firing. That's very, very, very rare. The 1C agents can be used for atrial and ventricular arrhythmias, but they're more commonly given for SVTs. And so Dr. McConnell may talk about their use in atrial fibrillation. What I want you to understand is that we do not use these agents in patients with structural heart disease. So this was the CAST trial that was in, I don't know, the 80s, 90s, way ago. I learned about it in pharmacy school, where these patients had increased mortality. So in structural heart disease. Now, what do I mean by structural heart disease? It's anybody who's post-ACS, anybody who has valvular disease, anybody who has left ventricular hypertrophy, anyone who has heart failure with a reduced EF. So that limits their use to patients without structural heart disease. You will see them used in AFib in those patients. Keep in mind that propafenone, these depress systolic function. That's why they can cause acute decompensated failure. And they also, propafenone has beta blocking properties, and they each have their own set of unique drug interactions. The potassium channel blockers are mainly used, well, they're used for atrial and ventricular. We tend to use sotalol and amiodarone more commonly for ventricular arrhythmias. Dofetilide is mainly used for atrial arrhythmias, although it's not FDA approved for ventricular arrhythmias. And keep in mind that sotalol is renally cleared. In ventricular arrhythmias, you don't necessarily have an absolute contraindication. For AFib, you do. In patients with creatinine clearances less than 40, for ventricular arrhythmias, if sotalol is effective, we might extend the dosing interval. Amio, of course, has its own set of very unique side effects that affect vital organs, and so you have to have all the baseline monitoring that's appropriate. So you want to look at PFTs because it can cause pulmonary toxicity, and the thyroid function test because you can be euvolemic or not euvolemic, euthyroid or hypothyroid or hyperthyroid after its use. It can cause LFT elevations in the skin. You can have purple tones. Gray tones come to the skin, and there's ophthalmologic deposits as well in the eyes that can be reversible if you stop. But the big thing about amiodarone over a long period of time, if you're using it for a ventricular arrhythmia, is watching out for pulmonary toxicity. And again, it has drug interactions, multiple drug interactions as well. Okay, so now that was our background of antiarrhythmics, and we're going to continue on with our life-threatening arrhythmias. These aren't the arrhythmias that appear in the algorithm where you might consider defibrillation or not, but these are still rhythms that are common enough in the inpatient world that we will talk about. One is symptomatic bradycardia. If a patient presents with a bradycardia, and they are stable and they are asymptomatic, we generally just observe them and we don't do anything. It's when they become symptomatic that we give atropine. We usually start at 0.5 milligram of atropine, and it go up to a max dose of 3. And if that patient doesn't respond to atropine, or you've reached your maximal dose and you need other support, the guidelines don't recommend one over the other, but you're either going to have to go to transcutaneous pacing or a pressor in this individual. Included in the ACLS guidelines are SVTs, and if the SVT that you are given is narrow complex, if the tachycardia is a narrow complex, it's most commonly an SVT. If it's narrow and you can try to use vagal maneuvers to stop the rhythm. If that doesn't work, you may have to go on to using adenosine. Remember, adenosine is a complete AV nodal blocking agent, and it has a very, very short half-life. When you give it, you have to elevate the extremity. You usually push doses very quickly. You might have to overcome a drug interaction in patients on theophylline caffeine or theobromine. That's common, right? No. You might have to limit the dose in patients who are taking dipyridamole or carbamazepine. Common, right? And then you definitely want to pay attention to the fact that this drug causes angina. If you've ever seen adenosine being given, you will never forget it. It causes angina in over 30% of the patients. And you don't want to use it in asthma either because of bronchoconstriction associated with its use. Just a word about unstable atrial fib where you are going to cardiovert immediately. Sometimes patients with atrial fibrillation with rapid ventricular response need cardioversion, and we are faced at that point in time with whether or not it's been 48 hours, can we immediately cardiovert without TEE, and we would do that if the patient was crashing. But if we have TEE available, we might do a transesophageal echo to see if there's a left atrial clot present, and then we would cardiovert them if they did not have a clot. I want to mention this because there are certain drugs you can cardiovert someone with AFib either electrically or pharmacologically. And electrically is probably a little bit more effective than pharmacologically or chemical cardioversion, but I see a combination of the two often used where we'll electrically cardiovert and then someone will be placed on a therapy at the same time. So there's kind of a dual mechanism. And so I want you to be aware of the guideline recommended drugs that are used for the acute synchronized cardioversion of atrial fibrillation. If you can remember DIP-AF, you will have the drugs that can be used if your atrial fibrillation has been, if the AFib is less than 7 days of onset. So basically, they're your potassium channel blockers, so your dofetilide, your ibutilide, and your amiodarone, and then the two 1C agents. And remember, you're not going to use the 1C agents in patients with structural heart disease. So the longer a patient's in AFib, the harder it is to cardiovert them into normal sinus rhythm. So what's the hardest stone? Diamond. So remember DIA, dofetilide, ibutilide, amiodarone. Those are your potassium channel blockers. So if AFib's been longer than 7 days, those are the drugs that at least have shown some efficacy in treating AFib that's been in existence for greater than 7 days. Now we're getting into the wide complex tachycardias. Basically, we go to amiodarone if it's a wide complex tachycardia. You can, if it's monomorphic, the guidelines will say you can use adenosine. That is not to cardiovert that rhythm. That is just to slow the rhythm down so that we can see what it is, the underlying rhythm. So, of course, sotalol and procainamide can be used, but you would not use those if you had heart failure, for example. Torsades is something that I think pharmacists really need to be aware of. This is a polymorphic VTAC, and this is someone who, most commonly torsades happens in someone who has a drug interaction, drug that causes QT prolongation, or someone who has low magnesium or low potassium. And so we generally want our potassium and our potassium greater than 4, our magnesium greater than 2. And the best way to treat torsades is to prevent it. So look for those drugs that prolong QT, your macrolides, your phenothiazines, your Haldol, those types of drugs, and try to prevent that in the community. We have just actually one minute left, and I'm going to run through this case, final case, and we're going to take a few minutes break. So if you'll allow me to go into our break, just one more minute, we'll have time to finish the case. Sometimes we will have patients who, outside of the acute setting of ventricular arrhythmias, we need to address their chronic management of ventricular arrhythmias. And most of the time, ventricular arrhythmias, well, they're so varied. So a patient can present with benign ventricular tachycardia that's just non-sustained, that means nothing, or all the way to the life-threatening arrhythmias that we've already discussed. And so what it boils down to is that ventricular tachycardia sustained or not sustained, and does that patient have structural heart disease or not? And in a nutshell, those that don't have structural heart disease, if they're asymptomatic, we just reassure those patients. If they're symptomatic, everybody's going to get a beta blocker. Easy enough. If they have structural heart disease, then that becomes very important, especially if it's a sustained ventricular tachycardia. And this is a background slide. What I mean by sustained VTAC is that it's 3 or more consecutive PVCs. It lasts longer than 30 seconds. So you're probably looking at these patients on a Holter monitor or some of the newer patches that can monitor electrical activity. Or you have to do something to stop the rhythm because of the patient presenting with symptoms that are unstable. And most of the patients with structural heart disease are going to get an ICD. Medicare will pay for a device because the trials that have looked at antiarrhythmic therapy versus device therapy show that device therapy is better at reducing sudden cardiac death. So Medicare will actually pay for both primary and secondary prevention of sudden cardiac death in patients who meet certain risk factors. You got to have a life expectancy of greater than a year. And the primary prevention, someone hasn't had sudden cardiac death yet. Secondary prevention, someone has. Or we've got a reproducible arrhythmia. And their EF has to be low. So these criteria are worked out on who gets a device or not. But by far and away, if your patient can get a device, it will save their life more often and better than antiarrhythmic therapy. Amiodarone and sotalol can be used also to decrease firing. So let's say you put in an AICD and their VTAC is still going on, and that AICD fires, and that is very uncomfortable for patients. So sometimes we'll use drugs to suppress the firing of their AICD, and we have data with both amio and sotalol. They're not great, but they can decrease the firing. They're not going to affect mortality, though, any more so than their device will. So last case, patient admitted for syncope. He's seeing black spots. He's passing out. You see ventricular tachycardia. This is sustained VTAC on his monitor. He's got a history of heart failure with reduced ejection fraction. He's got LVH. He's got diabetes with neuropathy. Which agent is most appropriate for him? We're going to avoid 1C agents. We're going to avoid 1A agents and anyone post-MI. We're going to treat probably him not with sotalol because that is not appropriate for heart failure with a reduced ejection fraction, but we're going to go to amiodarone in this patient. All right, guys, here's what you do. Before the exam, get a good night's sleep. Eat before you go. Take a deep breath. Do not stress out. Choose two to eliminate, and then work out those differences. Look for reasons that one is contraindicated, and then go with your gut. I wish you all the best. Let's take a break, and then we'll get back in 5 minutes. 5 minutes.